this computer. All right, good afternoon. It is April 28th. And more importantly, tomorrow is my fiance's birthday. And if I don't get her something by then, I'm probably not going to be around to teach you guys anymore. So I'm just saying, if I don't show up, you know what happened. So we're going to cover a couple things. I got a few lists from you guys, like I said, just before we started here. If there's anything else you think of while we're going over the talking about the different stuff, please post it down in the chat for me and I'll cover it as we get to it. But like I said, the ones I got emailed on specifically are just covering the overview of ultrasound, like the specifics on kind of like the tree like I designed for eSTEM for ultrasound, so I can talk that through for you guys. And then also talking about the different eSTEMs. So a couple of you talked about depth of penetration, cryotherapy. We'll cover all that as well as we go through this. So I don't think it'll take the rest of the afternoon. Don't freak out like that. Let me get my little draw on iPad brought up here and we'll share screen. Testing out a new technique here of using the iPad as a whiteboard. Plugin is required. Install the plugin. Why is it not installed already? Oh, because I wiped my hard drive. That's right. All right. That makes sense. Tap screen mirroring and zoom. Move you guys over here. All right, you guys can see my little iPad screen right now?
Yes.
Cool.
Yep.
See, these are the technology things I'm learning about only after we're almost out of Zoom. Bring participants up just to be safe. There we go. All right, so let's first, because I think probably the idea here is depth of penetration is a really good kind of topic to cover in general. Just because there's a lot of variance in what you see on the boards and stuff like that, but it all breaks down to pretty easy. Most, and I'm going to say most, when I talk about most, I'm talking about hot packs, I'm talking about cold packs, I'm talking about even eSTEM to a point. There are some ways to make eSTEM penetrate a little deeper, but eSTEM to a point, fluidotherapy, whirlpool therapy, almost all the modalities. Does anyone know about what the max depth of penetration is? The max that you're probably ever going to see in depth of penetration, other than shockwave. Shockwave goes a little deeper.
Like 5?
Yeah, it's about 5 centimeters, so about 2 inches, right? So 5 centimeters is usually or about 2 inches. That is an N, I promise you. So that's the main thing that for your boards, at least, that you really need to know. Most modalities will go from about 3 to 5 centimeters. What can affect that depth of penetration? Well, fat layers. And I don't mean to sound like that, but truthfully, adipose affects almost every modality, right? That's just like everything else. It's an insulating material. It's going to protect you from cold. It's going to protect you from heat as well. It'll also cause you to retain heat, right? A guy like me, when I go out and run during summer, I am completely soaked in sweat because my body retains the heat I'm absorbing from the area around me. So there's a good and a bad to it, right? So adipose layer, hydration. If your patient is a really dehydrated patient, you know, they're little old Millie who's been spending her weeks in the nursing home, all the modalities may not work as well with her, just because she's not as hydrated. On the flip side of that, you know, sometimes athletes who either overhydrate or are properly hydrated, the modalities really react well with them because they usually have a lower, adipose to muscle ratio, and they're more adequately hydrated because they take a little bit better care of their bodies, right? But even with them, about 5 centimeters is the max depth you're going to get. So I feel pretty safe saying that if you saw a question on your boards or saw a question on your, your exams for Dr. O'Neill's class, that the most you really ever have to worry about is thinking about 5 centimeters. 3 to 5 centimeters is the normal. Now, when I say that, like with a hot pack or a cold pack, would leaving it on cause it to penetrate deeper? So like if I leave the hot pack on for a long period of time.
I mean, I think it would, but it could also cause tissue damage.
Right. And that's exactly where it can penetrate. And more importantly, the reason it's going to penetrate deeper is because it's more superficial tissue is going to get damaged, right? So as that tissue kind of gets damaged, it's going to penetrate deeper and try to damage more tissue. That's the theory of adding energy to the body, right? It sometimes can cause some problems. So when you're on your, and I will cover this, I just covered it with the other group. When you're on your boards, definitely a good safe rule of thumb is 5 centimeters and under. So now when you get a question on your boards, what are the questions going to look like for this? Well, they'll say something like the max depth of tissue penetration for cryotherapy is, and they'll say A, 20 centimeters, B, 1 centimeter, C, 4 centimeters, or D, 8 centimeters. So if you look at that and you go, well, Mr. McKeever, you said the max depth of penetration is 5 centimeters, right? Remember I said 3 to 5. So that's where you go, okay, well, this one falls in that range. So that's my choice. All these other ones are out, right? Now, if it said something like shockwave, which is not, because there's not questions on your boards about shockwave therapy, so golf clap for that right now. You know, you could theoretically go to the 8 centimeter mark, but they're not going to ask you questions on shockwave. Does that make sense as far as depth of penetration really goes for all of the modalities? Even ultrasound, about 5 centimeters deep is about you're getting. So, you know, about that deep, right? Do I have a ruler handy? Yeah, I do. So let's see.
Is it just because like we're not using shockwave therapy as much?
Yeah, there's not a lot. There's not a lot of research out there yet on it. So as it becomes more prevalent, it will become more questions on the board. Like when I took the boards way back when, we didn't have a lot of questions on laser. Actually, we had none. Now there's maybe 1 or 2 questions on laser.
Would we know like if there would be like kind of like new topics?
Yeah, that gets reviewed every 5 years. And we're the next 5 years, I think. So we're, what year is this? 2021 now. The next one is 2024 is when the review comes up.
Oh, for sure. Okay. Thank
you.
You
Guys are okay. There's nothing changing between now and then. They actually just sent us last week the surveys, because they send the schools out to the surveys out to the schools to ask what our students have encountered out in the wild and stuff like that. So they will ask us and we give them feedback on what to kind of put on the boards. I was actually originally going to be a question writer for the boards, but then I found out that if I become a question writer, I can't help you guys prepare, because if I get the inside track on writing the questions, I can't also help you guys prep for the boards. And I said, well, I don't want to do that. That's no bueno. All right, so let's talk ultrasound now. And again, when I think ultrasound, for me, I like to develop those little flows like I developed with eStim, right? So when we talk about ultrasound, the main idea, ultra, really high sound waves, we can't hear it, right? I've had patients like, oh, every time you turn that thing on, I can hear it. No, you can't. No, you can't. Stop that. You're not a dog. Even dogs don't hear ultrasound. But even that, we know that ultrasound is used for multiple things, right? You guys are going to use ultrasound in the clinic for healing patients, but we also know that ultrasound is used to image babies, right? It's also used on carotid arteries to look for blood clots. They can use it on the brain too for cranioimaging, but it's not as effective, obviously, because skull's in the way. They can image your urethra and stuff like that to see if you have kidney stones. So then what do you think the difference between that type of ultrasound that you would see in imaging versus the ultrasounds you guys are going to do is? What do you think is the difference?
The depth.
Depth, okay, yeah.
The healing effects?
Frequency. You're going in the right path. Both of you go in the right process, right? The frequency is the main idea. The frequency changes, right? So what are the 2 frequencies we deal with in ultrasound?
1 and 3.3 megahertz.
Yeah, and I'm going to break that down a little bit even. I usually say 1 and 3. 3.3 is a kind of standard setting, but you may still get machines that are just 3 megahertz, like the kind of beige machines are 3 megahertz, but like the newer towers are 3.3. So whatever.
So if we have like a question on our test for modalities and it has 3 and 3.3, what would be the best for us to pick?
Well, it would depend, and that's what we're going to talk about now.
Oh, okay.
Right? Because it would depend upon your depth of penetration. So when I'm faced with an ultrasound question, this is the way I think through them, and I'm hoping that it will make sense in the long run. The first thing I do when I'm faced with an ultrasound question is I ask myself for two different things. Is it a heating ultrasound or is it a healing ultrasound? Meaning, am I looking to heat up the tissue or am I looking to use ultrasound to repair tissue? So I say the patient's got, low back tightness. To relieve tightness, I'm going to have to do what to the tissue?
Heat it up.
Heat it up, right? Whereas if I have an ACL tear, or even let's go with an LCL because LCL is probably more common. An LCL tear, heating is not going to do anything for that, right? But what we want to do is heal that. So a lot of times, like I said, the first thing I ask is, am I going for heating or am I going for healing? So tissues for heating, right? Muscle. And within a small range, the ligaments in the muscle too. And the tendons. But only if I'm trying to warm them up. So what kind of words would you see that you think would clue you into warming up or heating up tissue?
Tightness.
Tightness.
Yeah.
Right? Sore could be as well, technically. Right? Lack of motion. Right? Because we know that heating up improves motion, whereas cooling down using ice kind of restricts motion. So those are the things I'm looking for. Is it saying, tightness? Is it saying restriction? Lack of motion. Those are the words I'm looking for with regards to heating. And then for healing, I'm looking for stuff like vasodilation. Yep, there's exactly. Vasodilation could be another one, right? I'm looking to increase the blood flow. So let me sneak that in here. So increase blood flow would be another one for heating. For healing, I'm looking for words like tear, break, callus. Because again, with ultrasound, we typically don't do ultrasound over fresh breaks, but if they've got a hard formed callus, we can, right? So this is the first thing I try to figure out. So I'm looking at an ultrasound question and I will literally take, and when you're at the boards, you'll have a whiteboard or a piece of paper beside you that you can write stuff down. I'll read the ultrasound question and okay, so I'm looking for heating or am I looking for healing? I'm looking for healing and I circle it, right? Or I circle heating, depending upon what I'm looking for. That's going to determine what?
Like
What
how
Yep.
the megahertz
Not the megahertz yet.
or the frequency?
Not the frequency yet. That's
The
megahertz.
depth of penetration, right?
Not depth of penetration yet. We're not there yet.
Acute or chronic?
Not really. It's going to determine the duty cycle. Do you remember that one?
Oh yeah.
So the heating, well, I don't need that. I don't need two L's. Let's try to spell cycle right, huh? So duty cycle is what we talk about, when we're talking about it being a continuous or a pulsed. Do you remember that?
Yeah.
Yeah, right? So which of these, heating or healing, is continuous?
I think that healing is continuous.
Heating is continuous, right?
So I have heating is continuous, I have healing. Do I have to make a poll? No. So think about it this way. If I put a hot pack on a patient and I put it on, I take it off, 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 is it going to heat up the tissue?
No.
No.
Healing
No,
is-
right?
yeah.
That's the idea of pulsed. That's why I'm going through this, because I'm hoping this will help you guys. So heating is continuous. Healing is pulsed. Pulsed is going to work a lot more along those really high level, the microjet and the cavitation line, right? Of causing those water flows to occur, that if you read your book, they went way far in depth into it. And you probably looked at it and just got all glazed eyes and went, I have no idea what they're trying to say there, right? So a duty cycle is whether we're looking at continuous or pulsed. Now, if you go pulsed, there are different duty cycles, right? And depending upon your machine, usually you have 50%, 30%, and then 10%. You may have a 20% in there too, depending upon the machine. This is where I get into this. Oh, Mr. McKeever, what do I pick there? Right? Well, then I start looking at my patient. So let's say it says patient has an LCL tear and we're doing ultrasound to that LCL tear. Well, I'm going, okay, that's a healing. I need to do pulsed. Then I need to look at my patient. Because if I've got a bigger person, meaning I have more tissue, I am probably going to do a higher duty cycle. If I have somebody, that's got itsy bitsy knees, I'm probably going to do a little bit lower duty cycle because I want to avoid that tissue heating up. The higher the duty cycle I go, the greater chance I have of heating up tissue. Right? So if I have a larger person, it's going to disperse. And that was one of the questions I had about the surrounding tissue. It's going to disperse a little bit more and less likely heat up that tissue, where we don't want necessarily heating when we're trying to heal something. So when we look at these duty cycles, one of the things I'll always say to students is it's always safer to start low and go higher. It's always safer to say, let's start, I'll get you in a second. Let's start at 10% and go to 30. Let's start at 30% and then go to 50. It's always okay to do that. Yes, what was your question? I saw it pop up.
Yeah, I was just curious, so is there a way to tell if you need to go up? How can you tell that it's not enough?
And that's going to come on that's going to partially come on you working with the PT, right? So maybe you've done 2 or 3 bouts of ultrasound with the patient and you've gotten not much in results. Then we might bump that duty cycle up some. Does that make sense? When we do this, the patient's not going to feel anything, right? Or they shouldn't. I mean, if you have somebody, like Brooke's kind of a tiny person, she may feel some heating from the 50% duty cycle, where you put that, even if you put continuous on me, I still don't feel anything. It doesn't heat up my tissue because I've got too much protective layer, as we said. It just, ultrasound really doesn't affect me all that well. This is where they're going to say, after you do ultrasound, they're like, I don't really feel nothing. And that's where I talked about that magical phrase where I say, I understand you didn't feel anything, but this is occurring at the cellular level. And it may take a little bit for everything to kind of kick in and for those ultrasound waves to cause a reaction in your body. It is completely possible to go the whole way up here to 50% and not really get much out of it. It just is. Because it may be that for whatever reason, the person just doesn't respond to ultrasound, right? There are people that take allergy meds because they have really bad allergies and they get nothing out of the allergy med except maybe falling asleep. It's just the way we're kind of designed. So it may be that ultrasound's not the modality for them. And maybe we go 7 sessions, we're like, hey, they're not getting anything out of this, and talk to the PT and say, can we try something else? But I tend to start at 30% for most things. For most patients, 30% is okay. The only time I really do 10% is if I'm working on a hand, just because really there's not much to a hand, right? And I don't know, did you guys do the underwater ultrasound?
She only demonstrated it to us, but we didn't actually try it out.
We'll try it out a little bit next semester during lab, just so you can get the feel of it. It feels weird at 50% and 100%. So like if I've got trigger finger, I've got a tightness, right? I've got a bind down. So we're gonna have to do continuous for that. But man, for whatever reason, when I do usually people like, it feels like my skin is crawling, is the way I've had it described to me at continuous and 50%. When would I use healing on the hand? Maybe I've got a ruptured ligament in my finger. Well, then I'm going to use healing instead of a heating effect. That's kind of the process of it. John, what was your question?
Yeah, so on the pulse on that one as well, would we ever use maybe like 60% to 90%, or would we just go straight to continuous if that's the case?
I mean, I guess you could. I don't think I've ever. I'm going to be honest, in my clinical experience, I don't think I've ever used anything over 50. Just because, again, the higher I go, the more I get the thermal effects, the less I get the healing effects. I believe in ultrasound. I'm actually one of the few that you'll find a lot of clinicians don't even believe in ultrasound anymore. They just think it's a bunch of hoo-ha. And I believe ultrasound does some really good things. I don't necessarily always believe in the heating effect of ultrasound, but I definitely believe in the healing effect of ultrasound. I mean, you theoretically could, if the machine does 60, 75, 90%, you theoretically could try it. There's nothing, it won't hurt the patient, right? The only time you'd really ever hurt a patient with ultrasound is A, if you don't move the ultrasound head, or B, if they have cancer or one of those contraindications in that area. Other than that, you can't really hurt them with ultrasound. If you guys didn't get a lot of practice with it, that means nobody got burnt, which really upsets me. I like somebody to be my example when we're doing it, that somebody forgets to move the ultrasound head and burns one of their fellow students. So I can say, don't do that. Because if you're on continuous and you don't move that ultrasound head, you can burn the patient. So that's why that movement is so important, right? What is the duty cycle when you see continuous? What is the percentage? When you say continuous, it means
100%.
100%, yeah. The only reason I bring that up is sometimes the board might get tricky, and instead of saying continuous, they'll leave it as 100% and expect you to understand that 100% means continuous, right? So that's my first kind of fork when I'm going. Am I going for heating or am I going for healing? Does that part at least make sense so far?
Yes.
Okay, am I overloading you guys yet?
No,
Oh.
not yet.
Not yet? All right, I'm going to erase all this again. Like I said, it will be saved on the lecture for you. So we're going to erase. So now once I've determined if I'm doing heating or healing, the next thing I have to determine is the thing that you guys were all just trying to use there. What was the next thing? How deep I need to go.
Depth penetration.
Yeah, depth of penetration. How deep do I need to go? That's when we get into this, which is the frequency, right? This is our frequency. And again, 3.3. I'll put 3.3 down here, and we'll talk why 3.3 is a little different than 3. Let's say I have a patient and I'm working on the paraspinals of the back. Which frequency am I going to pick? Everyone's like, I'm scared to answer.
Is it like 3.3 since you don't want to get like too deep?
Well, actually, the paraspinals are really deep. There's a lot of fascia overlaying the paraspinals. Honestly, I'm hoping Dr. Johnson's trying to talk Dr. Chatelli over at UNLV for us to get in and see the cadavers they dissected. So if you see that, and you see a freshly dissected cadaver, you'll be amazed at the thickness of the fascia that is overlaying. My answer, no, don't. I know, that's why we're doing this, John. Please don't. You're good. This is the way we learn. This is the way we ride the bus. Wait, no. So usually when you have a larger area and you want to go deeper, you're going to use which megahertz? You don't have to. We're not going to make you, Riley.
1.
Yeah, 1. This is our deep penetration. And then shallow, and then shallower. So deep penetration for big muscles. Like, let's say we had ultrasound of somebody's calf. That's a big muscle, right? Especially if it's the gastroc. The gastroc's a huge honking thing on most people. Even on tiny people, the gastroc's a big hunk of meat, right? The glute. Glute would be one we definitely want to do 1 megahertz on, especially if it was like saying, warm up the glute plus the piriformis. We're probably never going to get down to the piriformis, but we can pretend. Now, let's say instead of that, I'm now saying that we want to work on the extensor muscles of the wrist. You need to heat up the extensor muscles of the wrist. Is there a lot of meat out here?
No.
No, right? So then we're going to go with the other two, either 3 or 3.3. So would the boards ever be mean and put 3 or 3.3 on? No. So take a deep breath on that. The boards will either have 1 or 3. A lot of times what I've seen on the boards is they'll have 1 megahertz, 3 megahertz, and then they'll say continuous or pulsed. And when you're dealing with depth of penetration, continuous or pulse doesn't even matter. So you're looking at 1 or 3, or they may say 3.3. Then you're going to determine if you're going deep or shallow. So when could Mr. McKeever put a question that you could go, well, is there a reason to use a 3.3 instead of a 3? Hand. Right? Think of, if I'm trying to work on those little muscles, the feathers of the hand here, they're really superficial. And there's not a lot of meat on most people's hands. Now, some people do have ham hock hands and they have a lot of tissue. But most people, there's not a lot of tissue in their hands. So then if I had a question that said, you know, which of the following megahertz would you pick for somebody that has trigger finger of the hand where they have a contraction? Then I theoretically could put 3 and a 3.3, and 3.3 would be the better answer there. But that would just be being mean. And I hope that there wasn't a question that was mean like that. I can't guarantee that. But I could totally see myself doing that. So that would be a reason why I would pick 3.3 over a 3. Let's think of something like the levator scapula, right? Levator scapula is a fairly shallow muscle, and it's a fairly small feather-like muscle. That one I'm going to do a 3 megahertz. But now let's change that. Instead of doing levator scapula, now I'm talking the traps. Are the traps a pretty broad, thick muscle?
Yeah.
Yeah. Even most people, like when the doc did my spinal surgery, he joked with me when I came out of surgery. He was like, because I had to dull 10 6 blades to get through your traps. He goes, I thought you were big, but I figured that was just all fat. I'm like, thanks, doc. But yeah, when you see people doing spinal surgeries, it sometimes takes them forever to get through those trap muscles to get down to the spine because they're a really thick layered muscle. For those, we're probably gonna do 1 megahertz. So if I have a contracture of the traps where I'm like this, 1 megahertz probably would work better out here on that nice thick trap and also hit a little bit of supraspinatus underneath, which is probably bound up. If upper trap's bound up, that one's probably bound up. So I can get a little bit of overflow and irradiation with it. So thicker, deeper muscles, 1 megahertz. That's our deep treatment. 3 megahertz is our shallow muscles, like the lateral epicondyles of most of your arms and legs, right? Tibialis anterior. That would be a fairly shallow muscle, right? If you're going shallower, hands and feet are definitely probably a good idea to do 3.3. Does that clear that up at least why you would use 3 versus 3.3?
Yes.
Cool.
Yeah. Is there like certain parts of like the hand, or I know you mentioned like if they have, you know, bigger hands or like feet, where we would like use one, like for example, like maybe the calcaneus or
Yeah,
like,
I've used one. The main reason I've used one before is doing phonophoresis, where I'm driving medication in. Then I have used, especially like on the calcaneus or down in the plantar fascia of the foot, I've used one then, but the only problem that happens is you have to use a lower pulse setting then, because those sound waves going in and hitting off those little itsy bitsy bones of the hands and feet, sometimes, like I said, can cause it to feel really weird. And patients don't like it. Like I've had patients that love ultrasound of the low back or the calves or the hamstrings. And then you do something like their hand and they're freaking out. It feels weird to them. So yeah, you could theoretically, like, especially if I'm personally, when I've worked in a clinic, when I've driven medication, I've definitely used 1 megahertz, but not very often. Maybe if I'm putting some medication here in the thenar eminence.
okay, thank you.
You can do ultrasound on the low back as long as you stay off the what?
Just stay off the spine.
Stay off the spine, yeah. And let me tell you, Mr. McKeever's little trick to that when I was going through school. Because one of the things my teacher always made me paranoid about is if you take the ultrasound head over the spine, it could trigger a reflex reaction. Because it can. The sound waves can get down in there and hit those anterior horn cells or the posterior horn cells and trigger a reflex reaction, right? A sensory overload, basically. So what Mr. McKeever's trick is I always took my pen, I palpated where my spinous processes were on my patient, and I laid my pen on the spinous processes, whatever it is, plural process. And that gave me a guide where not to go. And I stayed away from my pen. All along those paraspinals, you absolutely can do it on. You just can't do it on the spine itself.
So would that be a precaution or
It
not?
would be a precaution, yeah.
Okay. So contraindication would just be, oh gosh, I forget exactly how.
What's your big contraindication that you can pretty much save for all of your modalities?
Malignancy?
Malignancy, yep. There's your big one. Malignancy and fresh fractures are pretty much what you can save for all of your comps coming up.
Pregnancy.
You can pretty much say, do you have a new fracture? Do you have any new cancer I need to be aware of? Are you pregnant? Those are kind of the common ones.
Okay.
Right? A precaution would be, yes, definitely if they've got if you're going towards the spine, that's a precaution. That'd be where you're going to protect it.
Okay.
And if you're not comfortable, that may be one where you say, hey, can I see how you do that? If you're a student, right? Can I see how you do the ultrasound in that area so that I can mimic you?
Okay.
Right?
Is that a precaution also I don't know if I'm saying it right, but the
Epiphyseal plates, yep. So growth plates, right?
Is that a precaution or a contraindication?
So here's where this is where it gets, and this is up to the PT to decide, not for you to decide, Brooke. If we have a fracture of the epiphyseal plates, we can do pulsed ultrasound on it to help the fracture heal. But if they are a kid and have epiphyseal plates that are not fractured, that would be a contraindication. So if I'm doing ultrasound, I wouldn't want to do ultrasound of the lateral epicondyle of the humerus on a kid because the growth plates are still open there, if that makes sense.
Yes, and I think if you put it over, doesn't it almost make it want to fuse together?
Yeah, it can. Yeah, or the worst part, it can vibrate it apart a little bit, and it causes them that growth. We all encountered that when we were growing up, right? You had those growth pains. Mm-hmm. You can cause those to kick in by hitting ultrasound over them.
Okay. And what is the age of that when they're fully developed? Is it 21 or 18? I forget.
Well, I mean,
I think we had one of these questions on the test too.
So if I was looking at a question on your boards, it would say probably 18 to 21, because who's going to develop slowest?
I would say,
Men or women?
I don't know, because I know girls stop growing quicker than men. So
There you go.
okay.
Right. So maybe if I have a volleyball female athlete
Mm-hmm.
who's 18, I might be okay to do that.
Okay.
Right. But if I have a male athlete, I'm definitely going to check with the PT before I do it. I'm going to say, hey, you know, say he's a tennis player and he's got tennis elbow or something like that. I'm going to say to the PT, hey, you know, think of those epiphyseal plates. Do we really want to be doing ultrasound down there just to be safe? And if he says, go for it, I'm documenting per PT ultrasound of, and I'm covering my butt. Because the goal of your whole life after you get licensed is protect your license.
For like exam purposes,
Mhm.
you know, talking about like that epiphyseal plate, is it usually just for like, if it's just contraindication, it's usually for like a younger?
Yeah, so the question would say something like, which of the following patients would you not want to do continuous ultrasound over the lateral epicondyle of the humerus, right? And they'll be like A, 45-year-old, right? B, 65-year-old. I forget how to do the female one. This way, right? And C, it might say 19-year-old, and it could be either male or female at that point, right? And then D, a 31-year-old. At that point, that's how their question's going to be. They're not going to make it difficult. They're not going to have like both a 21-year-old female and a 19-year-old male. If you look at these, there's definite age gaps here, right? We're like, oh, okay, those two are definitely okay. 31, okay, yeah. Although I would hasten to say that some of our ladies here would argue if 31-year-old men are mature or not. That's okay. This is our warning, right? Or more than likely, what it'll probably be is something like this. Be like 9-year-old, and then we're definitely avoiding it. It doesn't matter if it's male or female. We're avoiding it because it's a kid. They're not. The boards are made to be tricky, but they're not going to be blatantly rough on you, if that makes sense. They're not going to put something where we've got a 19, 18, 17, and a 21-year-old patient and go, which one of those don't you want to do ultrasound on? And we're like, all of them? I don't know, right? Out of all of those, the 21-year-old would be most safe, right? But they're not going to do that mean to you. And I can attest to that from going to the class on writing the board questions. The board questions are made to be difficult, but not be a jerk.
And then, so for like kind of example of like Dr. O'Neill's exam, usually she would say like, all these are contraindications except this.
So in that case, it would say, how about this? All of the following are contraindications of ultrasound except, and so we'll say A, malignancy. That is malignancy. I promise. This is why I don't write anything for you guys. B, 22-year-old male at lat epi. C, over pregnant uterus. This is one of my favorite ones. We had to write a contraindication list. Over the eyes. So that tells me that at some point, somewhere, somehow, somebody tried to do ultrasound over the eyes. If we have to make a contraindication about it. And whoever they are, they need to be out of PT. So looking at that, and you're like, which one of those is not a contraindication? Well, malignancy is definitely one, right? That one's out. Pregnant uterus, out. Eyes, definitely out. This is your best answer. Even though it's pretty close to those epiphyseal plates and it's pretty close to them closing, that's your best answer out of that one. Does that make sense? I could also change this and say, like, I think it was Brooke didn't mention it. I could also say the, right paraspinals. There's an S there. Now, if Brooke thought that, like, hey, I thought we couldn't do ultrasound of the low back. Well, yeah, but out of those, that one's okay, right? But if it said over the, like ultrasound to the intraspinous ligaments, that would be a no. We don't do that over that area, right? That's on the actual spine itself. We're avoiding that, because when you've got your spine, and you saw that with Dr. Johnson, right? Let me get a place to draw here. I really like this fact that I can draw now. This is going to be my new toy. Right, so we've got our spine coming down the middle of our back. On either side of the spine, we have divots, right? That's those areas there where if you reach back that you can kind of put that space in, and you've got those, your pedicles and everything that you can get in. In those divots sit your muscles. If you're on those, you're okay, because usually at that point, the nerves are already past the horn cell, you're safe. When you get on that spine itself, you can nail the horn cell and kind of cause some, it's not going to kill them, but it could be uncomfortable. Again, like I said, I've had students that, we're doing the whole low back. And technically, if you're doing the whole low back, you should do the right side of the back, shut the machine off, stop it, go over and do the left side of the back separate. But I've had students that have jumped over the spine, and I tell them, not a good idea to do that. They're like, well, I just quickly went over here. Number one, it's not a good idea because the ultrasound head lost contact for a small period of time. The other thing is you still kind of went over the spine, and not exactly the best idea. Well, I thought it was okay. No, it's not. Mr. McKeever says so. But then you'll get Mr. McKeever who will do it because I'm bad. And I say, do as I say, not as I do. Does that make sense? Are we okay on the frequency? So we got one more thing to determine with ultrasound. So we got our frequency, we had our duty cycle. What's the last thing we need to determine for ultrasound? Anyone have an idea?
Is it, no, I was going to say acute or chronic, but that I guess would have to deal with if it's heating or continuous, I think.
Well, actually, I'm going to talk about that in a little bit. So save that one. That's a really good question here.
Isn't it like the wattage?
Yes. What's that called? You got it. It's the intensity, right? How strong. And the intensity is measured in watts per centimeter squared, right? So the amount of energy delivered in a square centimeter. So usually ultrasound goes somewhere between 0 and 5 watts per centimeter squared, most machines. I'm going to tell you, I have never, ever, ever in my entire career done an ultrasound, excuse me, hiccups there, done an ultrasound over 2 watts per centimeter squared. Never. And I actually asked a couple of PTs, none of them have either. Because once you get over that 2 watts per centimeter squared, that ultrasound head gets pretty warm. And it gets a little uncomfortable. And I'm just not going to do that. The nice part about what the intensity is, it goes up in increments of 0.1 watts per centimeter squared. So you can do something like 3.2. If you're in the clinic, I guarantee you're going to see this. 1.8 watts per centimeter squared. And if you ask me where that number came from, I can't tell you. It just seems to be the number that every PT and every PTA has used from eternity. It's not a good idea. It's not a good idea to always do the same intensity for the same, for different injuries, for different patients, for different body types, for different tissues. But for whatever reason, I have seen people that'll do pulsed ultrasound at 1.8 watts per centimeter squared. Continuous ultrasound, 1.8 watts per centimeter squared. And they all do it. I guarantee, and if you ask a PT or PTA why they do that, well, because everyone else does. That's not the right reason, right? And if any of you are techs, I'd be willing to bet if you've done ultrasound on a patient, you probably set it to either 2 or 1.8 watts per centimeter squared. Because that's usually what they do it on for, again, reasons. I don't have an answer why. What do you think is going to determine your intensity?
Pain level.
Pain level, good. Yep, there's one. Your patient, right? The size of your patient, right? If you've got a bigger patient, it's going to take more energy to get an effect. If you've got a bigger area, it's going to take more energy to affect the area, right? This goes back to that effective radiating area and the ERA and the BNR, which I'm going to hit high level and try not to get into Mr. McKeever levels of that and try not to get too nerdy on you about that. But a good rule of thumb is if you're doing pulsed, a good rule of thumb here, pulsed is good to do between 0.5 and 1.5 watts per centimeter squared. And the shallower the area, the less tissue the area, the lower the wattage. Whereas continuous, typically, we're going to do between 1 and 2 watts per centimeter squared. And that's where that magic 1.8 watts per centimeter squared came in, because probably somebody saw this and went, oh, well, then I can do that for everything. No, stop. But let's say I'm doing ultrasound on John and I'm doing continuous. He's got a calf injury and his calf is really tight. I'm doing ultrasound and I pick 1 watt per centimeter squared. And he's like, man, that's not feeling good. Could I turn it down? Sure. Yeah, I could go down into the 0.8, 0.5, 0.7 range. Sure, if it's uncomfortable with the patient, definitely. Or we could just discontinue it, right? It's because some patients just don't like ultrasound. It's just the way it is. They don't. So this is a kind of a good rule of thumb. If you have something that's pulsed, 0.5 to 1.5 is a good range. If you have something that's continuous, usually 1 to 2 is a good range. So let's look at something like the hand. If I'm doing of the tendons of the hand, right, probably want to lower my wattage down because there's, again, not a lot of tissue here. You're going to have an easier time delivering energy to somebody's hand. If I'm doing something like transversus abdominis across the belly, as long as it's not, he or she is not pregnant, then you might want a little bit more energy because there's a lot of tissue there. Does that make sense? These are really good rules of thumb for your test questions, just because I know I wrote those questions about that one. So I can pretty much guarantee she hasn't taken my questions out of the test for those, because I wrote most of the ultrasound questions. So if you have a pulse, picking something between 0.5 and 1.5 is a good goal. Again, lower for smaller areas or smaller people, higher for bigger areas or larger people. Right? Continuous, again, same idea. If I have Truman on one table and I have Brooke on the other table, and I'm doing the same ultrasound to them, I'm probably going to have Truman's intensity up a little bit just because he's got a little bit more tissue to him than Brooke has. Does that make sense? And I'm not calling you out for being fat, Truman. Don't think that, please. Does that make sense, though? Hey, I mean, I call myself out every day. So, you know, if I'm doing a kid, more protective layers, exactly. If I'm doing a kid versus doing an adult, yeah, I'm going to step down the intensity. Because, again, I've got a kid. I've got to think about what can happen. The kid's cells are still differentiating. I don't even like to do ultrasound on kids. I don't even like to do e-stim on kids if I can avoid it. Does that make sense so far? Are we okay? Did I lose anybody yet? We're breathing?
Yes.
Breathing.
Yes.
So this is the way my tree goes. I go, okay, am I going for heating or healing? I pick my tree there. The next thing I go, am I going deep or shallow? I pick my tree there. And then the next thing I go is my intensity. How much energy am I going to deliver? If you get a question, like if we were doing still the practicals, it's one of my favorite questions to ask you guys is, well, what intensity are you going to pick? And somebody usually says 0.5 to 1.5 watts per centimeter squared. That's not an intensity. I want you to say, I'm going to pick 0.7. Great, do it. Right? If you'd say 1.5, well, why did you pick that? Well, they've got a little bit more tissue in this area, so I'm going to want to deliver a little bit more energy, and it's a larger area. Great, do it. Right? You know, you're doing continuous ultrasound at the patient's low back, and you're like, oh, I'm going to start at 0.5. Well, why are you starting at 0.5? Well, I'm going to start at 0.5 because the last time I did this, the patient didn't react well. Great, that's a valid answer. Right? So like we had that. We had one student, I remember in, I think cohort 6, who when you did ultrasound, for whatever reason, if you got above 0.7, she giggled uncontrollably. She said it felt like she had little bugs crawling all along the area you're ultrasounding. She was really reactive to ultrasound. And so they learned really quick. If they had her as a partner, they only did like 0.5 watts per centimeter squared because she had a weird reaction to ultrasound. That's just one of those weird things that happens. The only other thing, and this goes back to, I think Brooke that asked the question about it, was the spreading through the tissue. And with ultrasound, that's going to come down to your ultrasound head, right? And with your ultrasound head, you have two main numbers you watch. You have your BNR and your ERA. And ERA, for those of the guys that are sports people, is not earned run average, right? BNR is beam non-uniformity ratio. Does anyone remember what ERA means?
Effective radiating area?
Yeah, effective radiating area. So if I have a bigger ultrasound head, like the 10-centimeter ultrasound head, it's going to have a higher ERA. It's going to affect a larger area, right? So usually a good rule of thumb with ERA is most ERA is 1 centimeter smaller than the head, but it's on the tags. So if you get a question on your sheet that says, on your test that says, where would you find the ultrasound's ERA and BNR? It's on the tag on the ultrasound head. I'm going to say that again. If you get a question that asks you, where do you find the ERA and the BNR? It's on the tag on the ultrasound head. Every ultrasound head has to have it. And technically in the clinic, if you are in the clinic and the ultrasound head doesn't have that tag on it, we can't technically use that ultrasound head because that's a requirement for safety. Right? So if I have something like a 10-centimeter ultrasound head, usually the ERA is about 9 centimeters. I think ours over at the school is 8.5, close enough, right? We also have a 5-centimeter sound head. What do you think the ERA on that is?
4?
Yeah, 4 centimeters. So what does that mean? Well, your ERA is going to determine the area you're treating. So do you remember how big or how ERA affects it? Well, the ERA, you're going to treat 2 to 3, oops, I didn't want to put that yet. 2 to 3 times your ERA. So if I've got an area that is, say, 17 centimeters, the 4-centimeter head is too small because it's only going to treat an area of about 12 centimeters, 8 to 12 centimeters squared. Whereas the 10-centimeter, which has a 9-centimeter ERA, so 2 times that is 18 to, why am I drawing a blank? 27 centimeters squared. Basically what this is saying is the bigger area you're treating, the bigger head you're going to use. That's what it all boils down to. So let's say I'm doing the low back again. Probably going to pick the bigger sound head, right? Unless I'm treating somebody like Stephanie's tiny. Might go a smaller sound head on her because she's got a little bit smaller of a body. And that's going to determine, like, if I'm only treating an area like this big on her, yeah, then I need the small sound head. If I'm treating the whole low back, still can go with the big sound head, even though she's small, just because I'm treating a larger area. And remember that when you're talking about square, right? So this is 10 centimeters squared, 4 centimeters squared. That's talking about the length and the width of an area, right? So you get a box. Does the ERA make sense? So again, if you get a question on your board or you get a question on your test, what does the ERA relate to? You can treat 2 to 3 times the size of the ERA. So let's say we have an area that is 36 centimeters squared. Well, now this sound head is even too small for that. So we have to do one of two things. Either get a bigger sound head, which I don't know that there are bigger than 10 centimeters. That'd be a really big sound head. Or we grid the area. We split it into 2 sections. So we'll treat for 8 minutes in one section and 8 minutes in another section. That's that gridding technique that was talked about in your book. If you read it, probably none of you did. Does ERA make sense? Okay, this is taking longer than I thought. I'm sorry. I apologize.
Yes, makes sense.
Okay. So, Brooke had brought up about how it radiates out into the surrounding tissue. That's this BNR. If we have, what do you think an ideal, the best, because it's going to be a ratio, so that means it's something to something. What do you think the best BNR you can get is? What's the best ratio? A 1-to-1 ratio, right? 1 to 0 is not very good, right? You always want to have 2 people. It's just the way it is. 1-to-1 ratio. 1-to-1 ratio would be the best. What that literally says is, if I have my ultrasound head here, and the ultrasound head is delivering my sound waves down into the body, all of my energy is staying in that sound head and going straight down the whole set of that sound head. The higher your BNR goes, the wider it spreads. Most ultrasound heads, and the ones we have in the school, are 1 to 3 ratios. I'm going to erase the ERA part down here so I can have more area to draw. I need like a 50. I need one of the, like the whiteboard that Wolf Blitzer uses. That's what I need. The one he uses when they're doing like the presidential races and stuff like that. So let's say this is my 5 centimeter sound head. You do not have to do the math, so don't freak out. I'm just going to do the math so it makes sense. I have my 5 centimeter sound head. I said that my ERA is 4 centimeters. If I have a 1-to-1 ratio, that means my beam stays in that 4 centimeter range. If I have a 1 to 3 ratio, that means it's going to cone out. So some of the energy is going to be delivered straight down, but some of the energy is also going to come out to the surrounding tissue. That's okay. It's not going to hurt the patient. It just means that you're not getting as effective delivery of that energy. So when we have a higher BNR, the worst I've ever seen is a 1 to 6 ultrasound head. And that ultrasound was crappy. It never did, like, it didn't work with patients. That means that if I've got a 4 centimeter sound head ERA, it's delivering it over 24 centimeters, right? So that 4 centimeter sound head is delivering it over this whole section here. That is not a very effective delivery of medication or of energy. So for your BNR, the only thing you're really ever going to get a question on is, what is a better BNR? A lower number is a better BNR. So 1 to 2, 1 to 1 is ideal, right? So if I had a question on your test that said, you know, which of the following sound heads has the best BNR? And I would say something like A, 1 to 4, B, 1 to 2, C, 1 to 3, or D, 1 to 12. Which of those would have the better BNR?
1 to 2.
Yeah, the 1 to 2. That's the lowest ratio. That means 50% of the energy you're delivering is being delivered to the area that you want it to be. That also means 50% is being delivered elsewhere. That's just the way the science works with the crystals, unfortunately. There's not much we can do about it. The higher quality crystal we have in the sound head, the better BNR we get, which also means the more expensive the sound head, right? Because the more expensive that crystal gets in that sound head, the more expensive the sound head's gonna get. Most ultrasound machines use a quartz, which usually is about a 1 to 3 to 1 to 5 ratio. There are some ultrasounds out there, like over in Europe, that they can use where they'll use something like tourmaline or not emerald. There's another green gem. I can't think of what it is right now. But they can use other kind of crystals that deliver the energy a little bit more focused. Ironically enough, with lasers, it's the same idea. So with beam non-uniformity ratio, the lower the ratio, the better. Where do you find the beam non-uniformity ratio? If you need to look it up, where do you find it?
It's not on the tag, is it?
It's on the tag.
Okay.
That's going to be your goal. So your tag will say, if you look at the tags in the school, it will say BNR 1 to 3, ERA 4 centimeters. And it does have some other gobbledygook on there that's not as important for you guys. That's more important for the guy testing the machines. But that's kind of where you're at. So if you get a question on your board, or not on your boards, on your test, again, I'm going to say it. If it says, where would you find the ERA? You find the ERA on the tag for the sound head. Where do you find the BNR? On the tag for the sound head. What's the better BNR? A lower number. So look for the lower number. And then ERA is relating to how big of an area you can treat. Does that help? That is pretty much ultrasound in absolutely the quickest gist I can cover it. That was longer than I expected, but it's because I run long. I may have to record some of the E-stim because I don't want to keep you guys past 5. Are you guys doing okay?
Yes.
All right. I'm gonna erase this. I wish there's one thing I need, is it needs a erase whole board. Doesn't have that. I have to actually erase like it's an eraser. Although it does kind of remind me of being in the classroom, so I kind of like it. We're gonna be back to the classroom soon, guys, I promise you. We're in there talking today about how to move stuff around to spread people out more. Okay, so with E-stim, the first thing I'm going to cover with E-stim is the E-stim I actually didn't work with you guys on yet, because I worked with you guys on TENS and IFC. I want to cover NMES or Russian because I didn't get to work with you guys on that, and I had some of you guys that said you were a little confused by it. Would anyone agree with me on that? No one's going to agree? Do you at least understand how to set it up overall? Okay, I got a yes, good. So when I say NMES, it means neuromuscular, right? Electrical stimulation. You're triggering the nerves to cause the muscles to react. That's all it is. Most common is Russian. Again, I mentioned on the board, the second most common is VMS. In the clinic, you might see a company called Bioness. Bioness is just specialty NMES machines. That's all it is. They make special units for the wrist and they make special units for the foot. It's an NMES machine is all it really is. They make little portable NMES machines. They also have the ones like we have where you have to plug into the wall. The portable ones just don't last as long because they've got a battery and you've got to charge the battery every day. So with NMES, right? The main idea here is we're trying to re-strengthen or retrain a muscle. The main thing here is they have to have a manual muscle test grade of 1 or greater. If they don't have a grade, if they have a grade of 0, which means you don't even get a twitch, there's nothing there. You tell them to lift up their hand, right? And nothing happens. They do wrist extension, right? It doesn't do anything. There's no twitch, there's no nothing. E-stim's not going to help them. They're not going to ever get better. That muscle, the nerve going to that muscle has been damaged profoundly. So we're not going to really be able to help them. If they have a twitch, that still means they have some voluntary contraction, which means E-stim can help them. And it can help them strengthen when they can't strengthen themselves. That's why we're doing it. So the first thing you have to do is know your anatomy, right? If I'm going for tibialis anterior, you have to know where to put the pads for tibialis anterior. So you're hitting tib anterior and not the peroneals, right? Same idea with that, with wrist drop, right? Where you're doing wrist extension. Well, if your hand is doing much more radial deviation, you can replace the pads. That was that question. It says, can you replace the pads? Absolutely. You can, when I say replace them, meaning to move them. If you're getting more radial deviation than you're getting of actual wrist extension, you're more on those radial deviators and maybe probably a little bit more of brachioradialis. You're getting a lot more of that kind of going on, and maybe even some of the thumb muscles. So reposition the pads a little bit. Okay, now let's try, because again, all of those muscles are out here in that lateral compartment of the arm. And they're all in a bundle that goes along that way. The higher up you go, the more you're getting the true wrist extensors, the less you're getting the radial deviators. Same thing happens over here for, if we're doing flexion, the flexors are a little higher up, right? Whereas more of the deviators are a little bit further down. Same thing with the leg. Tibialis anterior is a little bit higher up towards that fibular head, whereas the peroneals are a little bit further down the leg. So if you have a question on the board that says, or your test that says, your patient is, you're performing, dorsiflex with the patient with Russian, and you're getting more, I was going to say external rotation, but we're not calling that. We're still calling it eversion. You're getting more eversion. What should you first of all do? Turn the machine off, move the pads, because that means the pads are in the wrong spot. Make sure you're in the right spot to begin with, right? So like if we have the leg here, here's my tibia, right? That's my wonderful tibia. Here's my fibula, right? That's how good I'm at drawing. This is the lateral compartment. Your tibialis anterior is kind of right up here below the head. If you come down here, you're going to hit the peroneals, and that includes both pads. So the closer you can put both pads to the muscle belly, the better you're going to be. The more likely you're going to get the response you want. Now, even the best clinician will get a little bit of eversion when you're doing dorsiflexion, because the peroneals are there too. You're going to get a little bit. What you may see is a little bit of eversion, then it goes up into full dorsiflexion. You want to make sure that you crank it up a little bit before you start going, oh, maybe I need to move pads because I'm getting a twitch of eversion. Same thing with the wrist. If I start seeing a little bit of radial deviation, I'm not concerned. If I only see radial deviation, I'm concerned. If I see no extension, then I've got to move my pads. And we definitely, as PTAs, can relocate the pads. And for patients, honestly, I'm going to be 100% honest, it's a trial and error thing. I've had some, even students, where I try to get their tibialis anterior to fire, and I can't get past that eversion because their legs are tiny. And no matter what I do, so I have to go down to little itsy bitsy 1-inch pads, and then I can get full dorsiflexion. Because the muscles are so small, not small as in, not small for their size. So that's the pad placement type question there. Does that make sense? Does that help answer that question there, John?
It does. It does.
Yeah.
Thank you.
You think? I like it. With Russian or with NMES, you do still have a duty cycle. You have a couple of things. You have a duty cycle and you have a ramp time. Does anyone remember what the ramp time is?
2 seconds.
Yeah, 2 seconds is normal, good. But what does it mean? What is 2 seconds?
It means it gives them time to get adjusted to how strong it's going to be.
Yeah, so the longer the ramp time, the easier it is on the patient. It takes longer to reach that full contraction. But the longer the ramp time, the less they spend in full contraction. Does that make sense? So ideally, 2 seconds is kind of the most ideal ramp time. I tend to do 1 second with most of my patients because I'm mean. But 2 seconds is typically what you're going to see. So you can adjust the ramp time if patients can't tolerate it. The duty cycle is one of the more important ones. The duty cycle, you'll often see something like 4 to 12, 15 to 15, 10 to 30, 10 to 10 are some of the common duty cycles. You guys remember seeing that on the machines?
Yeah.
Right? So what this means is this is the on and off time. So if I have a 4 to 12 ratio, what that means is the machine is going to be on for a full 4 seconds. And then they have a 12-second rest. And then on for 4 seconds. And then a 12-second rest. Now, this is the caveat. Let's say I have that 2-second ramp time. That means I'm only going to spend really 2 full seconds in that full extended position because the first 2 seconds I'm building up to it. Does that make sense? So that's why, you know, again, that ramp time can become important, especially if you're doing a low duty cycle. The most common ones you'll see in the clinic are 4 to 12 and honestly 10 to 10. Some clinicians do 10 to 30, but most don't. 10 to 10, 4 to 12 are kind of your commons because it makes sense. 10 seconds on, 10 seconds off, 10 seconds on, 10 seconds off. And that'll help determine how many cycles you're doing per minute. I like 10 to 10 because it makes my brain easy. If I have a 10 to 10 ratio, how long does it take to go through one cycle?
20 seconds.
20 seconds. Yeah, right? Makes it simple for my brain. That means every minute I'm doing 3 contractions, right? 20 seconds, 20 seconds, 20 seconds, 60 seconds. I get 3 contractions in a minute. Does that make sense for everybody? See what I'm saying there?
Yep.
When I get up here to this 4 to 12, this is telling me that every cycle is 16 seconds. Oh God, that means I'm getting about 5 and a little bit more per minute, 5 or more contractions per minute. Gets a little weird there. And getting the math gets a little hinky. So that's why I'm going to be 100% honest. In most times when I'm on the clinic, I only do 10 to 10. Going to be kind of mean. I just am like, yeah, no, you know, I'm going to do 10 to 10 because it makes my brain easier. We could do 10 to 30. We could do 15 to 15. It just depends upon what we're going for. I give longer rest periods to newer patients. So if I've got a patient that I'm seeing for the first time, I may do 4 to 12. If I get a kid that's non-compliant, that happens. I may do 4 to 12 because kids don't like this Russian E-stim at all. If I've got a kid that's got something like where they've got a plantar flexion contracture and I'm trying to use E-stim to move them into dorsiflexion, they do not like E-stim. It hurts. It may even megahertz. Funny. Oh, that's great. So how do you know how long you're going to do Russian for? Well, either one or two things is going to come from your C or your PT. They're either going to say, do 8 minutes of E-stim at 4:12 ratio. Or they'll say, and this is where it gets into the pain in the butt, do 20 contractions at 4:12 ratio. Now you got to do math. And that kind of sucks. Because I go, well, 4:12 is 16 seconds per cycle. It's going to take me 5 contractions-ish a minute. So I'm probably going to need at least 4 minutes to get 20 contractions. I did that really quick in my head because I've been doing this for a while. You may actually have to write out the math if you're in the clinic so that you get it right. It's always better to do 1 or 2 extra contractions than it is to short them contractions. So if you're like, well, if I do 4 minutes, they're actually going to get 21 contractions. Okay, that's fine. That's still 20 contractions.
Can you just sit?
Go ahead, I'm sorry.
Can you just sit and count?
Sure, absolutely.
Okay.
Yeah, and it may be more beneficial to sit and count because you can bill for attended E-stim where you're sitting there with them versus if you're not sitting with them, it's unattended and is less reimbursable. So sure, you could. You absolutely could set it, just leave it on 20 minutes and count until you get 20 contractions and then shut it off. Sure. It's just more timing. And honestly, in the clinic, I usually don't have time to do that unless I am working with the kid. And I find that if I'm working with the kid, it does work out better that way because then I can be like, okay, here comes number 19. Let's go, pull, 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 right? And it gives them encouragement and they're less likely to try to pull the pads off. That happens too. What I'm saying is kids are pains in the butt. That's kind of what I'm saying. That's Russian, I mean, literally in a nutshell. The only other thing you have to know is knowing your muscles. So if I have to do extensor tendons, I'm doing the lateral compartment of the arm. If you're next to them, try to see, yeah, if you're there with them, and that's going to come into play when we talk about billing in 5th semester. If you are doing the E-stim and you're there with them that whole time they're having E-stim, that is considered attended E-stim. If you set up the E-stim, you give them a timer, you give them a bell, and you walk out of the room, that's unattended E-stim. And we'll talk a little bit about that. The main difference is you can bill multiple units of attended E-stim, but you can only bill 1 unit of unattended. Just because they say, well, we're only going to reimburse you for doing one thing, not with them, kind of idea. This is also why in a lot of clinics, they will do IFC with a hot pack because we can't bill for hot packs. They've just determined, Medicare has said, I'm sorry, they can put a hot pack on at home. We're not going to reimburse you for that. So we can put E-stim on them with that hot pack and get an unattended E-stim unit out of it. It's a way to get a little quick unit out of your patients. Or we can put a cold pack on them while they're doing Russian. There's all kinds of things we can do to make it a little bit more comfortable for them. But Russian itself, I'm going to tell you, it's one of the few modalities that they will not go home in less pain than they came in. Because Russian's not going to typically make it feel better. It's usually going to make it feel a little bit worse because they've used the muscles. So a lot of times they'll say, man, I wasn't sore before you did that stim, but man, now I'm sore. Good, that's your muscles thanking you for using them. And I'll joke with them about that and probably get smacked. But it is true, right? When you exercise your muscles, they get a little sore. That's normal. We teach them, okay, well, go home, drink some water. Make sure you ice it a little bit when you get home. It'll feel better in the morning, I promise you. It'll be, my phrase my mom used to always say to me is, it'll all be better before you're married. She lied. Does Russian overall make sense? Is there any questions on Russian you're not understanding about NMES?
What did we do for, I remember for my comp, I did 5-5. What was that option again?
Oh, okay, there is a 5-5. I forgot the machine. These machines have a 5-5 option.
Yes.
That's the duty cycle. That's all that is. I'm so used to the machines I've worked with at the clinic They usually don't have a 5-5 cycle. That's great. That 5-5 cycle, it still makes it easy, right? That's 10 seconds per cycle, right? That means you have 6 cycles per minute. Math is easy then. And again, most PTs are going to try to make the math as easy as they can on themselves too. So they'll pick those easy cycles as well. Because none of us like to do math in the clinic because we don't have time. Half the time we're trying to figure out what we're doing and if it's working. Any other questions on Russian?
So in this case, when like for exam wise, for example, like with Dr. O'Neill's, would she, at least would we get asked like the frequency and
Not with Russian.
and all that? Okay.
Yeah, not with Russian. Frequency doesn't play into it. There is, oh my God, I'm trying to throw out. There is a scan with Russian too, but that we don't mess with. I mean, almost never. There are higher level thinkings with that aren't part of PTA clinic or the PTA training. That if you ever get where you're being trained as a neurospecialist, they'll talk about how to change the scan of Russian and what ramp times affect muscles, what way, but that's a little higher level thinking. More likely, you'll get questions for Russian about, where would you place the pads for, and the reason I say this again, because I might have helped write some of these questions, where would you place the pads for an extensor activation so that you're doing extension of the wrist? Well, that would be the lateral compartment of the arm, right? Where would you place the pads if you're doing dorsiflexion? Again, that just distal to that fibular head is where you're going with that. So those would be more of the questions I'm going to ask you, or I may ask you, if you have a duty, I don't think she will. I would say if you have a duty cycle of 10-10, how many contractions are you going to get per minute? Well, 10-10, 20 seconds times 3 is 60 seconds, 3 contractions per minute.
She also mentioned something about, because looking into like our parameters for eSTIM, for NMES, that we're just going to use like 40 PPS for muscle tetany.
Yep.
And it would never go like lower than that.
Yeah, that's the frequency. So that actually be 40 hertz. And again, that the reason she said that you're pretty much going to use that, muscle tetany means a full contraction, right?
Okay, yeah.
And the reason she said that again is because there are different neuro theories about doing 60 hertz or 60 pulses per second versus 20 pulses per second. But that's like here, and you guys are kind of here. So
and I mean, the machines are typically already
set up 40 pulses per second. Yep.
Okay.
Yeah, you're usually going to use almost the machine. This is one of the ones where you will use machine default for frequency. Just like with IFC, where you use a 40% scan and don't really change it. Same idea. There are high-level reasons why you change a scan, but again, beyond your level of comprehension right now.
Okay. Thank you.
Yep. The main thing is understanding ramp time and duty cycle for Russian. That's the biggest things I can say. So, ramp time is the time for it to get the full contraction. Duty cycle, how long it's on and how long it's off. And then that 40 pulses per second, she threw that in there. I don't think I ever asked a question about that, but she may have thrown it in there because she taught it. So no 40 pulses per second or 40 hertz. Any other questions on Russian? So I know I want to try to hit, I know somebody asked about when, why is this not getting anything anymore? Did my pen lose connection? Hold on here. There we go. My pen lost connection. That was weird. I want to hit at least, because I know I had a question about it, when to choose IFC versus when to choose TENS. Because that's a really good question. There's a couple easy answers to that, and there's a couple more difficult answers to that. What do you think the easy answer on? So when, I'm going to write it down here. That's W. I should have been a doctor with my writing, right? TENS versus IFC. So remember, I said they're basically essentially same modalities. What do you think the most basic reason you're going to choose TENS over IFC is?
I'd say like placement of electrodes.
Okay, there's even more basic than that.
Pain.
Even more basic than that. Which one's portable?
Yeah. For like home
Yeah.
or
Yeah,
versus
yeah.
the clinic.
That one's more for home and work, right? Whereas IFC is a lot more for clinic. Now, somebody came to me and sent me an email showing that their clinic has an IFC portable device. Congratulations, your clinic has one of those. I think I've seen 0 of them ever. Great. That's actually cool. Your clinic has an IFC. That's something new, right? The main idea for the when you would choose it is if I'm sending a unit home with the patient, I'm going to probably use TENS in the clinic because I want to make sure that I stay as close to everything they're getting as possible, a uniform treatment pattern. Because if I bring them in and I do IFC in the clinic and they're doing TENS at home, they'll get, so this is where we get into patients with addictive mindset. So like, well, I like IFC better. So I'm not even doing the TENS at home, right? And that kind of gets a little difficult then. They're like, well, no, you need to be doing the TENS at home. That's why you're not getting over this pain. So TENS home is more for kind of home and work use versus IFC, which is more for clinic use. That's the most basic. The second answer I'll say is IFC is better at dealing with swelling. TENS can help with swelling, but IFC is much better at dealing with edema. By far, like hands down. There are even specific edema settings in some of the more fancy machines. There's even a setting that says IFC for edema. And it sets it up specifically just for swelling. So patients that might be lymphedemic or something like that. And I've used that on patients that are lymphedema. I've used IFC on them, and I've also used high volt, but that's beside the point. So again, those are the two major ones. There's, both of them have an acute and chronic, right? Both of them can treat acute and chronic pain. Both of them can treat, pretty much everywhere on the body. I mean, there's not a reason you can't. Can you, and I had this question in both groups, can you use just 2 pads with TENS? Sure, you can. They just don't get as much out of it. The TENS is designed for those 2 channels to actually work with each other. So you can, it's just not going to be as effective as using all 4 pads. So like if you have an ankle and the only pads you have are big 2-inch pads, you theoretically could put TENS on with just 2 pads, or you can kind of position them and move them around so you can get all 4 pads on. You get a little bit better result out of it. And again, the pads can be, literally the pads can be set up where they're right next to each other. As long as there's even a little bit of space between them, you're okay. You just can't put the pads like this where they're overlapping each other on any E-stim, because that actually can cause a short out. You don't want to do that. That can cause a burn. So if there's anything I'll say to watch out for is don't put your pads on top of each other. That's kind of like the Ghostbusters. You don't want to cross the streams. Same idea here.
So if we get a question that has like a picture in terms of like pad placements,
Mm-hmm.
You kind of just went over that like a while back, that if it's parallel to each other, then it's usually just TENS, and if it's crossed, then it's usually IFC.
So like if I was giving you a question, I said, identify what type of E-stim I'm doing. And I put a pad here, and I have channel 1. What type of E-stim is that?
IFC.
That's IFC, yeah, because the streams are crossing, right? Versus if I say, okay, whoops, that's going to erase the whole thing. Something like this, where I go, the pads are in line, that's going to be TENS.
Okay, thank you.
Now and there's not a question like this, but I could go like this and go, what kind of E-stim is that? And there's not enough information at that point, right? You don't have enough information just by looking at 2 pads to know if it's, because this, I mean, literally, this could be pre-mod, this could be high volt, could be Russian. There's any number of ones you could do with that. So you don't have enough information to answer that question. If you have the 4 pads, if they form the eye, right? If they form the eye, that's tens. If X going to give it to you, that's IFC. Rip DMX. His funeral procession was wild to watch. Does that make sense?
It does. Thank you.
Yep.
Also, would we ever, I mean, because we didn't really go over like high volt or pre-mod.
We're going to talk about that when we get into wound care.
Okay.
Because that's more along the lines of wound care and also edema control, which falls into wound care as well. So we will talk about that a little bit more. And if you go on, if you're out in your clinic and your clinic uses high volt, that would be a time to be okay to contact us, to like text me and say, hey, I don't remember about this high volt. Can you walk me through it tonight real quick? Yeah, sure. That'd be okay. Right. So if we haven't covered it or something, but we will cover it. It's the main thing you just have to know is high volts for right now is high volts for wound care and for swelling.
Okay. Thank you.
The only other question I can say here that you might get on your test is which E-stim is DC, direct current?
Tens.
Tens. Yes, right? The main idea is which one has a battery. That means it's direct current. That means it's tens. So technically, the person that sent me the picture of the IFC unit is operating off of a direct current, but somewhere in there, there's that alternator that's causing it to switch to an alternating current. And it's more along the lines of IFC, right? IFC is more of an alternating current. Most of the E-stim that's on that machine is alternating current. So tens, or not tens, IFC, Russian, high volt. Now you'll get funny is some of the machines will have a direct current hookup on the machine. That's converting alternating current back to direct current. It's kind of wild. Let me see if there was something, I thought there was something else. And for best time to use the E-stim, it just, again, depends on where you're sending them. That's the main thing with that is if you're sending them home, and honestly, I use more tens than I use IFC just because it's easier. And I'm going to be 100% honest about this. When I'm in a clinic, I can sell them a tens unit really easy. And it makes a little bit of money for the clinic, right? So most tens, honestly, like wholesale, most tens units are about $20 to $25. Some of the more expensive digital ones are like 30 to 35. And I could turn around and sell a tens unit for 50 bucks. All day, every day. Because patients are like, I could buy one of these and have one of these for when I'm at work. You absolutely could. And they're like, sold, here's my 50 bucks. Or I say, could you bill it to my insurance? And I look at their insurance and they have Blue Cross, and Blue Cross covers the cost of a tens unit. I'd be like, absolutely, we can bill it to your insurance. Do you want one? And we'll set up and order one. So that'd be another reason that's not gonna be on your test, but financially, you can make a little bit of a quick profit off selling a tens unit. And it's not wrong to do that. It's okay to make a profit. It's not right. It's not right to defraud your patient. Does that make sense?
Yes.
Is there anything else I can answer on the E-stim that you guys you're not getting, you're having problems with? I definitely wanted to hit the Russian because I know I didn't talk about it. Your brain's fried now sufficiently? Yes, I think a little.
Pretty much.
Okay. Did this help?
Yes.
Good. That's the main thing. If it helped, I'm okay with whatever else, as long as it helped a little bit. You know, you guys, I think your finals are starting next week, right? For some of your classes?
Well, I count our lab practical as the first of our finals.
That's the first of the finals, yeah, right?
This week.
I will say, don't sleep on Dr. Reskin's final. Take a little bit of time to review the stuff for her final. You guys know her quizzes are a little rough, right? We know that she's a good clinician, and she tends to challenge you guys with her quizzes and her tests. So don't sleep on it, still review it, right? And obviously anatomy, I would say don't sleep on any of them, but you know, judge your studying based upon where your grades are. You know, if you know that you don't need as good of a grade on, say, patho as you need in anatomy, you know, gauge your studying based upon that. It's one of the things they don't teach you a lot in school is we don't learn when and what to study, right? Gauge it. If you've got a high grade in one class and a lower grade in the other, focus more on that lower grade class. Bring your grades up to a homogenized level. You know, if I'm a director, say you wanted to go on for maybe your master's in healthcare administration, I much prefer a nice, even like B-level student than the one that's got like CA, 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 if that makes sense. Because that B-level student is a consistently good student. Does that make sense? I would rather have that. And obviously, I'd rather have somebody that's like all A's, obviously, because that's obviously me. I've never gotten a C ever in my classes. Never. Kept me from getting my freaking honors roll. Any other questions? Not bitter at all. You guys are doing well. I'm proud of you guys. I'm really proud that no one failed the practical. I am really, really proud of you guys for that. I don't know. I know you're not the first cohort to do it, but usually there's at least one or two that fail. So, I mean, I'm just going to say I'm proud of you guys for that. Really am. You guys are sticking to it. This is hard. You know, I know that you guys don't like doing the virtual stuff. I know I don't like it either. But the option is do the virtual stuff or don't have the class at all. And I'd much rather still have you guys in programming. So I'm just saying, I love you guys. I love y'all. You love the virtual? I don't care for it. The one nice thing about virtual for me is I can spend a little bit more one-on-one time sometimes with you guys. But once we're back to full on campus, you guys will find that I'm the one that's in all of your labs. I'm in there in those open labs with you all day, every day. Well, dogs, yeah. I don't have any pets. My poor kitty cat passed away a while ago, so. Any other questions I can answer? Other than why is my beard going white? It's because of you guys. The recording helps, yeah. And I'm going to do that even when we go back to campus, which probably will be your 4th semester full time. I'm still going to do recordings of the classes. I think it really helps you guys because you can go back and listen to it again. All right, I'm not going to keep you any longer if there are no other questions. You guys, if you need anything between now and then, please contact me. I'll be on your lecture or not your lecture, review on Monday with Dr. Johnson. But again, almost every single day from 11 to 2-ish, I'm sitting in my meeting room. I lately just logged in the morning and just stay logged in all day long, but I'm there for you.